Hello and welcome everyone to part 2 of the ACIP ICD-10 comprehensive two-part webinar. Our presenter for today is Marvel Hammer. Marvel J. Hammer, RN, BS, CPC, CCSP, ACSPM, CPCO, is an accomplished professional with considerable years of experience both in the business and medical fields. She is a coding, billing, and compliance consultant and owner of MJH Consulting based in Denver, Colorado. She provides medical coding and billing education, assistance with payer audits, and performs compliance reviews for her clients. Marvel enjoys teaching providers and their staff on correct coding and billing issues and presents on these topics nationwide. Her field of specialties include ICD-10-CM, addiction medicine, pain management, physical medicine and rehabilitation, neurology, and occupational medicine. Some of her pastime activities include wildlife photography and exploring the great outdoors. Now, without further ado, I'd like to turn the floor over to Marvel. Marvel, if you're ready, it is all yours.
Well, thank you, Emily, and I want to say again, good afternoon to those of you on the eastern part of the United States, and good morning to those of us on the western part. We're going to go ahead and get started today and jump right back in where we left off last week. And so from that aspect, we're going to be looking at starting out at Chapter 11. This is the diseases of the digestive system. Now, in interventional pain management, we don't report a lot of these codes from this system, but there's a couple of them. So I just wanted to touch base a little bit on this particular chapter. The code categorization follows that same path as the digestive system, starting with those teeth disorders. They've expanded a lot of the acute recurrent, chronic, or acute and chronic conditions. They've increased that specificity of the etiology of some diseases. So acute pancreatitis is differentiated as alcohol-induced, biliary, drug-induced, idiopathic, or other specific type. They also have a lot of combination codes for complications. The couple of diagnoses that we may see reported is the code, what we would have reported in ICD-9, 564.09 is other constipation. In ICD-10, we don't have a code specific for opiate-induced constipation. Boy, well, that's a word that's having a hard time coming out today. And so from that aspect, we're still going to continue to use the K59.09 code when we're reporting constipation. We'll talk about in a later chapter where we can have that correlation for an adverse effect from the opiates, but there isn't a specific code for opiate-induced constipation. Similar to the specificity that we see in acute pancreatitis, we also see in chronic pancreatitis. And so at the bottom of that slide 8 that you're seeing here is you can see that we've separated that 577.1 into actual two different codes. One is the K86.0 for alcohol-induced chronic pancreatitis, and then we have K86.1 for other chronic pancreatitis. And so certainly in some of our cases, depending upon your referral base, you may get patients sent over for chronic pancreatitis to deal with their chronic pain issues. Well, now we're going to shift into the meat and potatoes of today's session. We're going to spend a lot of time talking about this particular chapter, where it's the musculoskeletal chapter, and this is an easy one to remember. As we remember, ICD-10 codes will always start with an alphabetic character, and this is an easy one because it's the diseases of musculosystem, and so it starts with the letter M. So most codes have been expanded to include very specific sites, anatomic sites, and also laterality. And so that's where we get some of the big expansion. Also, this is going to be the first that you'll be exposed to use of some of the seventh character extensions. Now, the vast majority of the codes that we report in interventional pain are not going to require that seventh character, but there's a few of them, and we'll look at a few in this chapter, but more when we get into the S&T chapter, the injuries chapters. We've got combination codes now for osteoporosis, where we used to have to report separate codes to identify osteoporosis and the pathologic fracture. Now we have combination codes. Also, there's a note at the beginning that directs us to use an external cause code following the code for the muscular condition if it's applicable to identify that cause. There are also new instructions in ICD-10 coding guidelines. So again, those coding guidelines you're going to find in the very front of your ICD-10 code book, or last week I gave you a link that you can download that as a free PDF as well. Well, one of the guidelines states from this aspect is most of those codes in this chapter have site laterality designations. The site may represent the bone, the joint, or the muscle involved. And for some of the conditions where more than one bone, joint, or muscle involved, such as osteoarthritis, there are multiple site codes. Now, if the code category does not have multiple sites, then it would be compliant to report multiple codes to indicate the multiple sites. So, for example, if we have, pain in the shoulder joint and pain in the knee joint, and where there isn't a multiple site code, then it would be compliant to report both an ICD-10 code for that shoulder joint pain, likewise for that knee joint pain. So the first that we're going to look at is osteoarthritis. Osteoarthritis, as we talked about earlier last week in part 1, is the axis is reversed. Now in ICD-9, our grouping is regarding the type of osteoarthritis, and then within each of those categories, we have our anatomic sites. In ICD-10, it's just reversed. So our categories for many of them are based on the site, and then within those categories. So as you can see, we have a specific category, M16, for osteoarthritis of the hip, M17 for osteoarthritis of the knee, M18 for osteoarthritis of the first carpal metacarpal joint. And then in M19, we have that category is kind of our catch-all category, where it includes specific ICD-10 codes for osteoarthritis of the shoulder, the elbow, the hand, ankle, and foot. Just be aware of that when we're looking at these, the M16 and the M17. The other thing that I want you to point out to you is no longer do we have that kind of nefarious descriptor where M16 in ICD-9 it would be osteoarthritis of the pelvis and upper thigh, upper limb region. It's now used those anatomic terms hip. Likewise in the knee, and no longer the lower limb descriptor. They actually use the correct anatomic sites. So then looking at it, we know that it's reversed. So here's our examples of our osteoarthritis of the knee. So let's say your interventional pain management doctor is thinking of doing a genicular nerve block because the patient has chronic pain due to osteoarthritis of their knee. So we're going to look at, we start out with this indeed has bilateral code. So with that M17.0, we can see in that fourth and fifth characters in that first section, the M17.0 is for bilateral primary, where our M1711 and M1712 is for our unilateral primary right and left. Again, as typical as we pointed out in part 1, those right and left start with always from the right. Then our new descriptors, our new categorization is post-traumatic. So M17.2 is our bilateral post-traumatic. M17.31 and 32 is unilateral post-traumatic of the right and left. And then we have kind of a generalized for M17.4 is our other bilateral secondary osteoarthritis of the knee, and then M17.5 is other unilateral. It doesn't differentiate between right and left, that M17.5. So again, our axis in osteoarthritis when we're looking at them is first based on the anatomic site, which you can see by that code category M17, and then we pick up that specificity within that fourth and fifth characters for the various types. And our types now in ICD-10 are primary, post-traumatic, and secondary. Well, now moving on to the big changes is pain and joint for ICD-10. So we have to remember that excludes 2 that we talked about in part 1. Excludes 2, that 2 means that if the patient has it and we have documentation of it, is that we can in fact report both diagnosis codes. But you can see we start out with laterality. So again, we've got pain in the right shoulder and left shoulder with M25.511 and M25.512. We're now using those correct anatomic terms. Just like we had in the osteoarthritis, we have the term elbow, we have the term wrist, we have the term hip and knee. And so as you're working your way along, the patient may come in and have patient complaints of they've got bilateral hip pain. So as we know, the rules are is if we don't have a bilateral code, then in that instance, your provider would document that the patient has bilateral hip pain, and we would report that code M25.551 and M25.552. Again, in this particular code set for pain and joint, we don't have bilateral codes. So if the patient does indeed have both pain in both contralateral, both the sites that are the mirror image, then we could report, in fact, both. Now, on this next slide, this is to point out is that we've got, from this aspect, our TMJ disorders were moved actually from the diseases of the digestive system up to the musculoskeletal, where it really makes a lot more sense. We also have added specificity. So instead of having that kind of generalized 524.60 for unspecified, we actually have some greater specificity in ICD-10. So, for example, if a patient came in with TMJ pain, we'd be looking at that M26.62 code for arthralgia of the temporomandibular joint. So again, if in case the patient comes in, we're now going to be looking in the musculoskeletal section when you look through that alphabetic index under, say, for example, pain, temporomandibular joint. It's going to take us to the M chapter, not to that K chapter for the digestive system. Well, now shifting on. Now, this is a typical anatomic illustration for our spinal regions where we have cervical, thoracic, lumbar, sacral, and coccygeal. Where we'll see in ICD-10, we'll have that added specificity where we'll get new codes for the interim, where we have a code specific for cervical thoracic, which we're identifying as C7T1. We'll have a specific code for thoracolumbar that we're identifying as that T12L1. And likewise, we'll have a specific code for lumbar sacral, which we're identifying as that L5 S1 level. Now, also in many of our conditions, we'll also have separation in that cervical region. We don't see it in our thoracic and lumbar and our sacrococcygeal, but we do. And the one thing that I want you to remember when we get to that point is how our separation in the cervical is going to be dependent upon the condition. And I'll emphasize that more when we get to those conditions. So looking at our spinal region, pain in the spinal regions, it's a 1-to-1 crosswalk. So you can see our 723.1 crosses over to M54.2 for cervicalgia. It includes, the inclusion term is pain in the neck. I want you to point out, now that's if you have these printed off or make a mental note, this is a yellow highlight. This is an excludes 1. So if our pain in the neck or cervicalgia is due to either a disc degeneration or a disc displacement, say we've got a cervical disc herniation and we've got cervicalgia due to that, we're not going to separately code out the M54.2. That's going to be considered to be an integral component of that M50 code category, and it's not going to be separately coded. So also looking at the 724.1 crosses over to that M54.6 for pain in thoracic spine. Similarly, there's an excludes 1 for where we have a pain in the thoracic spine that's due to, again, either a disc displacement or a disc degeneration. And last but not least, we have M54.5. Now, we've got a slight change in our descriptor in ICD-9 that was actually lumbago. In ICD-10, the descriptor is actually low back pain. It does include those inclusion terms of loin pain and lumbago, not otherwise specified. The also point I want to make is, again, look at those excludes one. Remember the mnemonics of the excludes one, where one is from the aspect, again, is one means we can only report one of these codes. So if we have low back pain due to a low back strain, we're only going to report that low back strain because that's, again, that low back pain is a sign or symptom that we consider to be integral part of that diagnosis of low back strain. Likewise, if we've got lumbago or low back pain due to a disc displacement, we're likewise not going to separately code out that M54.5. We're only going to report the corresponding code from that subcategory M51.2. Now, looking at our big change here, now we certainly know our 723.4, that descriptor is less than optimal. So when we're looking at it, 723.4, brachial neuritis or radiculitis not otherwise specified, this is where we're starting to see that specific where we're getting into that specificity for spinal regions. So that crosses over to the M54.12 and M54.13. So again, we have cervical region and we have cervical thoracic. Another point that I want to make out, that this is another yellow highlight kind of moment, is look at the change in the descriptor. In ICD-9, the term is neuritis or radiculitis, where in ICD-10, the term now is radiculopathy. Now, again, we certainly know these terms are often used interchangeably in our everyday practices, but it is something that I wanted to point out. Now, looking at our go-to 724.4, that actually covers 3 different spinal regions. And so we have that separation out where we have a single code for 724.4. We now have that specificity for a potential for 5 different codes. So where we have M54.14, M54.15, 16, 17, and 18, and again goes from thoracic, thoracolumbar for that T12 L1 level. We've got lumbar sacral for an L5S1, and then we have sacrococcygeal region. So again, from this aspect, if we've got a patient that has, say, radiculopathy in both the T12 L1 distribution, but also L1, L2, L2, L3 in those specific 3 spinal nerves, we could report both M54.15 and M54.16 because there isn't a multiple sites code. Well, now looking at, we have a code, we also have a code for sciatica, M54.31. We do have that separation out. So even though we don't have laterality in the radiculopathy, I'm going to jump back to that radiculopathy side, and you can see there is no laterality. We don't have a code for radiculopathy lumbar region right. Radiculopathy lumbar region left. We don't have for specific spine levels in ICD-10, but we do see it in those codes for sciatica. And so that code M54.31 and M54.32, again, we have no code for bilateral. So if the patient has the condition bilateral sciatica, this is another example where we would report that M54.31 and M54.32. Now we've got new combination code here. If I were being asked to create a combination code, I'm not for sure that I would pair these 2 together, but they're paired together in ICD-10, where we have lumbago with sciatica on that right side and low back pain or lumbago with sciatica on the left side. The important thing to remember is if that patient does have that diagnosis of both lumbago and sciatica, the ICD-10 guideline specifically indicates we should only be reporting that M54.41. We should not be separately reporting that M54.5 and that M54.31 code. We would only report that combination code. So again, providers, if we have any providers on today's, or you're listening in through the recorded version, this is again that important of documenting that laterality, making sure that we have that clear specificity as well as that combination code, that low back pain with sciatica. We're looking at now ankylosing spondylitis. Again, itis is just meaning an inflammation. Ankylosis means stiffness or more often fusion of a joint. So ankylosing spondylitis is also known as rheumatoid arthritis of the spine. It's just a specialized term for that. So what's new in ICD-10 is we have much greater spinal region specificity. So we see we have that code 720.0 for ankylosing spondylitis in ICD-10, but we have no indication of the individual sites. So we start off with ICD-10, M45.0, where we do have a code in this particular category for multiple sites. And then we starting off, and this is the point I want to make, and I'm going to make this repetitively over. When we have conditions in the cervical region that are affecting the actual vertebrae, so we're looking at ankylosing spondylitis, we're looking at spondylosis, spondylolysis, spondylolisthesis, or we're looking at spinal stenosis. These will be the separations, the specificity that we'll see in the spinal region. So our first code, M45.1, is for occipital atlantoaxial. We specifically carve out that COC1, C1, C2 spinal level. Then we go back to our M45.2 cervical and M45.3 cervical thoracic. So if the patient, for example, did have ankylosing spondylitis of, we'll say, C4, 5, 5, 6, 6, 7, 7T1, we would instead just report that M45.0 code for ankylosing spondylitis in the spine. And on our next slide, we have where it again continues on. Now, where you're seeing the cervical and lumbar, we don't have that specificity. As I indicated, there isn't that specificity in the thoracic region for carving out T1, 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 2, T2, 3. It's just thoracic region. And then we go back to the thoracolumbar, our lumbar, lumbar sacral, and sacrococcygeal. So again, where we're starting with a single code from ICD-9, 720.0, we're adding multiple codes, but it's for the spinal region. And these are items that our providers already are aware of. They know this, and we should have documentation of it. If we don't have documentation of it, they just say ankylosing spondylitis. This is something that you would want to go back to, and you'd want to make sure that your provider adds that documentation for specificity. We don't want to use unspecified, be reporting unspecified conditions if at all possible. Well, here's one of our bread and butter codes where we have 721.0, cervical spondylosis without myelopathy. What we're seeing in ICD-10 is again that repeat separation in that cervical region where we have a single code. Again, we're in the M47, that's our spondylosis without myelopathy or radiculopathy, and we're adding that specificity with that 4th, 5th, and 6th character. So in that cervical region, we have that same COC1 and C1, C2 starts off. Then we go back to our cervical and cervical thoracic. So if we have documentation that the provider notes the patient has C7, T1 spondylosis, the code that we would report would be that M47.813. And again, then when we're looking at thoracic spondylosis, again, that's not reported as often. It's not as a typical spinal region that we see spondylosis. Not that patients can't have it, but it's just not as typical. We go back to our standard thoracic thoracolumbar, but more importantly, where we code that you probably report a lot in your interventional pain management practices with I9, or 721.3 for lumbar sacral spondylosis without myelopathy. The codes to look at is M48.816 for spondylosis without myelopathy or radiculopathy lumbar region, M47.817, spondylosis without myelopathy or radiculopathy lumbosacral region. And so again, looking at those two codes, those will probably be, again, what I call our bread and butter. You're going to get real used to, and I would bet that probably by late November, early December, you're going to have, oh, I know what that code is. It's M48.816, M40. Oh, I've got a typo there. It should be M47.816 and M47.817. So again, on your handouts, just make that notation. We've got a typo in that code for spondylosis without myelopathy or radiculopathy in your handouts lumbar region. That should actually be M47.816. My dyslexia was kicking in there. We have a whole new code combination in ICD-10 that we don't have the capacity to report in ICD-9. In ICD-9 actually states that if we have spondylosis and we have radiculopathy that's due to the spondylosis, that radiculopathy is not to be separately reported. And so in ICD-10, if you have a patient that has spondylosis without any radiculopathy, you're going to report those codes that we just went over, that M47.81 category, where in this condition we have other spondylosis with radiculopathy. Again, in our cervical region, we start out with that occipital-atlantoaxial. Again, this is a vertebral bone. This is a bone structure condition. You'll see that repeated over and over. We start out with that COC1, C1, C2, then we go to cervical, cervical, thoracic, and then we go back to our standard thoracic, thoracolumbar, lumbar, lumbar, sacral. My initial concerns for these codes were in many of our a Medicare contractor coverage policies for our facet joint procedures, they'll have statement. Now, not every single one of our Medicare contractor LCDs include this, but many of them do, that if the patient has radiculopathy along with the spondylosis, we need to work up that radiculopathy first. So I had some concerns that this code set, the M47.2 X code set, would maybe not be covered diagnosis for ICD-10 codes. And in fact, currently, of all of the ones that I looked through, and I didn't look through all of the jurisdictions, and I implore you to pull those down and look at your coverage policies, but all of them that I looked at for our facet joint procedures, whether it be injections or radiofrequency ablation, the neurolytic destruction did include this code set. So the M47.2X code set was considered to be a coverable diagnosis code set for our facet joint procedures. Well, now looking at spondylolysis, we have a couple of changes here from ICD-9. Again, spondylolysis is where, also known as a pars defect, where we have it's a fracture in that pars interarticularis. Now, again, this can either be an acquired condition or it can be a congenital anomaly. Our one big difference in ICD-10 is that the default diagnosis for ICD-10 is this acquired form. So if the patient does in fact have a congenital condition of spondylolysis, we're going to want to have our providers get in the habit of specifying that it is a congenital anomaly. It's a congenital spondylolysis. And again, this makes sense that we have and excludes one for that whole subcategory M43.0. So when we're looking at that, the congenital spondylolysis code, it's either going to be acquired or it's going to be congenital. So it makes sense that we're either going to report the code from that category M43.0 or that Q76.2 code. Also, what's new for ICD-10 is spinal region specificity. So like we saw in ankylosing spondylitis, we have in spondylolysis also that specificity. So we're starting out with that single code for the acquired form, 738.4. We're now seeing, again, in our cervical region, as I've reiterated over and over, and I'm going to say this, you'll probably get tired of hearing me say this, but again, we start out with that COC1, C1, C2 code specifically, then we go to our cervical, thoracic, and then we move on to our thoracic, thoracolumbar, lumbar, sacral, sacrococcygeal. And in this particular one, M43.09, we have a code for multiple sites. So again, in this instance, if we happen to have spondylolysis in the lumbar, so we have, we'll say L45 and L5S1, the code to report would be M43.09. I would just caution you to make sure that the multiple site codes are on your payer coverage policies rather than just having them include that specific anatomic spinal region for M43.06 and M43.07, and that may be the slight difference between our ICD-10 coding guidelines and what our payers require, how it needs to be reported. Well, now shifting on from spondylolysis over to the spondylolisthesis, again, we have that same kind of concept for spondylolisthesis, is that we've got additional spinal region specificity that we did not have in ICD-9. Also, that acquired form is the default diagnosis. And when I say that, if you go to the alphabetic index and you look up spondylolisthesis, the acquired is that default diagnosis. You have to go down to those essential modifiers, those lower, the listings below to find the congenital. So again, this makes sense. It's an excludes one. And what does that excludes one mean? The exclude one means that we can only report one of these diagnosis codes. So again, if this happens to be a congenital condition, this patient was born with it. We're going to report that Q76.2, and we need to have our provider indicate as such is that it was a congenital condition. In contrast, if they just document that we have C45, C56, spondylolisthesis, we're going to go ahead and the default diagnosis is that acquired, and so we're going to report that M43.12. So you can see why I'm now strongly recommending that our providers get in the habit. So instead of just saying cervical, instead of saying lumbar, actually indicating in our documentation, both in your E&M notes as well as procedure notes. Now, oftentimes in our procedure notes, we do have that spinal level specificity, but sometimes in our office visit notes, our E&M services, we don't get that specificity, and it will become important as you'll see throughout all of our spinal conditions. So again, new habit formings here. We would like to have the provider report that specific spinal level that we have spondylolisthesis. And so again, we're starting out in the cervical region, as I've indicated, because it's a vertebral condition. M43.1 for that occipital lanal axial, we go to cervical, thoracic. And then on the next side, you can see we can go to thoracic, thoracolumbar. So if we have documentation that it is an L5S1 spondylolisthesis, the code that we would report would be M43.17. We also have M43.19 for multiple sites. Now, the point is, in ICD-10, we don't have separation. We don't pick up a sixth character indicating the grade of that spondylolisthesis, that amount of slippage, the grade 4, the grade 2 spondylolisthesis, the amount of the slippage on that vertebrae, one on top of the other. Will we see that in ICD-11? I've not been able to see that in my lookings. I haven't done an in-depth look at that draft set on ICD-11, but we don't have any definition, any separation for the grades, but we do have anatomic sites. So we're going again from that 738.4, one kind of catch-all diagnosis code in ICD-9 as we do in ICD-10, that separation. The also point I want to make, in ICD-9, our code for acquired spondylolisthesis is the same code that we use for acquired spondylolysis. And I'm going to go back a couple slides just to point that out. So again, the 738.4 is the same code we use for acquired spondylolisthesis. where in ICD-10 we actually have separate code sets. So the M43.0 code set is for spondylolysis, where, as you see on this slide, the spondylolisthesis is the M43. We start picking up that specificity with that fourth character 1. So again, separate code sets in those subcategories for spondylolysis versus spondylolisthesis. Well, as we've pointed out, is that we have that additional specificity in the vertebral conditions, and I pointed out that ankylosing spondylitis, the spondylosis, spondylolysis, and spondylolisthesis in that cervical region, where it starts out with that CO, C1, C1, C2, then going to our cervical, thoracic. Likewise is the case for spinal stenosis. And so we go from 723.0 for spinal stenosis in the cervical region, where we again have those 3 carve-out codes. So we have a single code for that occipital axial. Then we go to cervical region. That would cover that C2, 3 through that C6, 7 spinal levels for spinal stenosis. And then we have C7T1 for that M48.3. We then go to our standard thoracic thoracolumbar. That's our crosswalk from our 724.01. The interesting point in ICD-9 is that a couple of years ago we got added specificity for spinal stenosis in the lumbar region, where we had specific codes either with neurogenic claudication, that 724.03, or 724.02 without neurogenic claudication. That concept of neurogenic claudication is gone in ICD-10 codes for spinal stenosis. And in fact, if you look through even the alphabetic index for the definition of claudication neurogenic, there is for vascular spinal, there is, but not necessarily neurogenic claudication. And so we go back to our standard M48.06 for lumbar, M48.07 for lumbar sacral. So from that aspect, M48.08 for spinal stenosis sacral and sacrococcygeal. And so just again re-emphasizing, the one thing in this particular code set, the M48.0 code set, is we don't have any specificity as to where we have that stenosis. Is it a central canal stenosis? Is it a neural canal stenosis? Or is it in fact a foraminal stenosis? Also, we don't have any underlying causation. So in many cases, the M48.0 code set for spinal stenosis is really considered to be a sign or symptom. Once we have a definitive diagnosis for that spinal stenosis, then we would then shift over to reporting that final diagnosis, whether it be in fact a large disc herniation, whether it be spondylosis, spondylolisthesis from that aspect. Interesting enough, in ICD-10, we have another code set. The one thing that is interesting in this particular code set is that in the beginning of the chapter for that M99 category, there is a specific note that directs providers that if we have any more specific code, then we should report those. And so here's what it specifically says. Under the M99 category, is this category should not be used if the condition can be classified elsewhere. So I really don't have any additional information as to what they mean from that aspect. This category also includes, where we're looking for our segmental and somatic dysfunctions. If you have osteopathic or providers doing osteopathic manipulation, but they also carry these. So we have stenosis of the neural canal, the M99.2 through M99.5, and then we have not only of the neural canal, but we also have that underlying causation. So whether it's a subluxation stenosis, an osseous, where we're looking at maybe it's a big bone spur, a connective tissue, again looking at that mild procedure, If we have changes in coverage policy where we have inflammation of the lumbar ligamentum flavum, this would be the code to be looking at, that M99.4. Intervertebral disc stenosis, again, where I'm giving you that range, it is the same exact range that we have in the spinal stenosis, the standard spinal stenosis, where it starts out with the occipital, atlantoaxial, it goes to cervical, thoracic, thoracolumbar, sacrococcygeal. Again, having those range just in conservation of space for the number of slides, I've just provided you with those range. We also have a separate subcategories for stenosis of the intervertebral foramina. So again, looking at, now we have combination codes of osseous and subluxation stenosis, that M99.60 through M99.69. And so again, where we have M99.70, M99.79, that range is for connective tissue and disc stenosis. So if we have a big lateral L4-5 disc and it's causing a right stenosis, intervertebral foraminal stenosis, we'll say L4-5, the code that we're going to be looking at would be that M99.73. So again, from this, we've got that specific range of that M99.73 for connective tissue and disc stenosis of the intervertebral foramina of the lumbar region. So again, different separations out here than what we're seeing from that. Again, that note in ICD-10 is this category should not be used if the condition can be classified elsewhere. Now shifting over to codes that we probably report. Again, some of our bread and butter codes for ICD-9 is our code 722.0 for displacement of the intervertebral disc without myelopathy. Understanding that that term displacement includes whether it's a disc bulge, whether it's a disc herniation, whether it's an extrusion of that disc, or whether it's a sequestration. We actually have a free fragment. All of those are captured in our 722.0 code, and likewise, that is the same in ICD-10. We don't have separate codes, whether it's a disc bulge, a separate subcategory for a disc herniation, a separate category for extrusion, or a separate category for sequestered or sequestration, that free fragment disc. They're all captured in that diagnosis code set for displacement. So we're starting out, and the one thing I want to point out here, now remember what I said earlier, all the vertebral, the bony conditions and spinal stenosis conditions are separated starting out at our occipital atlantoaxial, our COC1, C1, C2, then cervical, thoracic. Well, up until about 2014, that was how ICD-10 was. And then in our 2014 draft set, there was a revision. And it was a smart revision because, number one, anatomically, there are no discs at the C01 and C12 spinal levels. So we had some change in nomenclature. And they continue on to our 2016 code set that will be implemented October 1st. So we start out, any discal condition has these, whether it's a disc displacement, whether it's a disc degeneration, whether we're a disc disorder, you'll see in a second. Again, we have a note at the beginning of this category, the M50 category, that we are to code to the most superior level of the disorder. Now, this is in our cervical condition, our cervical disc conditions only. So we're looking at, we start out with high cervical, that's C23, C34. We then go mid-cervical, C4, 5, 5, 6, 6, 7, and then we go back to our typical cervical thoracic, which includes C7, T1. So again, looking at this particular rationale, you can see why, in my opinion, it's important to start adding that specificity to our documentation. So in your procedure note, in your E&M notes, that if the patient has a C5-6 disc, and we know it from a radiologic verification that it's a C5-6 disc, Then we're going to code that M50.22. Now, basing on that note, code to the most superior level, if that patient has a C3-4 disc and a C4-5, C5-6, we've got multiple levels there. Following that directive, that note, we would only report that M50.21 code. Again, I really implore you to look at your ICD-10 codebook and look at this code category, looking at that note, code to the most superior level of the disorder. This is only in our cervical range. We don't see that in the code categories for thoracic and lumbar. Again, we have high, mid. Because those terms high and mid from a clinical standpoint really don't tie into anything, my recommendation is to check with, if you have an EHR or you have super bills from that aspect, my recommendation is see if you can change those descriptors. Instead of having the descriptors saying other code disc displacement, high cervical region, consider in your EHR or your practice management software or any of your printed, say a super bill charge ticket in that place of high cervical, my recommendation would be, if you have the capability, do C2-3, C3-4. It's going to be much easier clinically from your providers to understand that. Likewise with that mid-cervical, C4-5, C5-6, C6-7. Again, rather than them trying to understand, particularly in these early starting out in October, what that high and mid-cervical is, certainly we all know the spinal level. That's something that is innate to this particular specialty, the specialty from interventional pain. But those terms high cervical and mid cervical are not as clinically used, and so from that aspect, I would recommend checking either with your software vendors to see if you can change those code descriptors, or if you're creating either reference sheets or your actual charge tickets that use that are paper, replacing that term high cervical with that C2-3, C3-4, and that mid cervical C4. Now you can do either the range C4-C7, or you can list it C4-5, C5-6, C6-7. Well, when we look over into our thoracic, we actually change to a different category. So again, looking at our cervical, all of our cervical disc conditions are in the M50 category, where our thoracic and lumbar following is the case where we see in ICD-9 is where we're looking at M51. Now we've changed categories. We go back to thoracic and thoracolumbar. We don't have a high thoracic and a mid-thoracic. Likewise, we don't have a high lumbar and a mid-lumbar. Also in that M51, we don't have any notation to code to the highest level of the disorder. So if the patient had, we'll say, an L4-5 disc herniation, we're going to report that M51.26. If that patient had an L5S1 free fragment, we're going to report that M51.27. But we don't have that separation out. We just have those bridge areas where for the thoracic. So if you're looking at the T12L1, we would report that M51.25. If you have that lumbar sacral, that L5S1, is the M51.27 code. Now shifting over to degeneration, again, because it's a discal, we again follow that note and we go back to the M50 category where we're looking again, we start out with that high where it's C2-3, C3-4, mid-cervical, 4, 5, 5, 6, 6, 7. Then we go back again to our cervical thoracic. So again, any condition that's related to the disc, whether it again be disc degeneration or disc displacement, whether it's herniation, bulge, free fragment, we're going to have that separation in the cervical region for high and mid. In contrast, if it's a vertebral condition, whether it's ankylosing spondylitis, whether it's spondylosis, spondylolisthesis, spondylolysis, that's where we have that CO, C1, C1, C2, that occipital, atlantal, axial, then going to cervical, cervical, thoracic. So very different structural arrangements depending upon what that condition is, whether it's a discal condition or whether it's an actual spinal stenosis or it's a vertebral, actual bony condition. So again, looking at this is code to our most superior level. So if the patient had disc degeneration of C5, 6, 6, 7, and C7, T1, following the note in ICD-10, we would only report that M50.32. Now, when we're looking at the thoracic and lumbar, we again change back to our category, the M51 category, where we're looking at from that aspect the lumbar region M51.36, other disc degeneration M51.37, that lumbar sacral region from that aspect. And so from that aspect, again, we do not have that direction in that instance where we have to code to the higher level. So again, if we have L4, 5, L5, S1 disc degeneration, it would be appropriate to report that M51.36 and M51.37. So again, from that aspect. Now, we have a brand new, just like we had for spondylosis with radiculopathy, we have a new combination code. And again, in ICD-9, if we had a disc herniation with radiculopathy, so that radiculopathy was due to a disc herniation, or we had radiculopathy that was due to disc degeneration, that radiculopathy we were directed to not separately code out that radiculopathy. We couldn't differentiate a patient that just had, as say, an incidental disc degeneration versus a patient that had disc degeneration with radiculopathy. This is the same instance, though, that we see in ICD-9. ICD-9 has the condition where we're looking at disc disorder. We don't have separate code sets for disc displacement with radiculopathy or disc degeneration with radiculopathy. It's actually combined together into the condition disc disorder. So we're looking at them. This is a new code combination. We also have a note because it falls under that M50. Where we're looking at, we go back to that high. In the note underneath in ICD-10, so if we're looking at that M50.12, this includes 4, 5, 5, 6, 6, 7, whether it's disc displacement or disc degeneration. And we've got C5, C6, C7 radiculopathy due to that degeneration or due to. So again, providers, this is a big important point. This is very important to have that linking term, because if we happen to have a patient that has, we'll say, for example, has cervical disc degeneration, but they have lumbar radiculopathy, we are not going to be reporting that M50.12 because that lumbar radiculopathy is not due to or associated with, say, that disc degeneration. It's actually going to be reported separately. So again, the importance of that understanding of that caused by, that associated with, that due to, and making sure we have that clear documentation. As you can see, the importance now, providers, of having that clear specificity instead of just saying, I've got cervical radiculopathy. If we've got a C5 radic due to a disc herniation, that code's going to be 50.12. If we've got a C8, let's say we've got a C7 and C8 radiculopathy due to disc degenerations at those two levels, again, following that spinal note, the ICD-10 note, we would only again report that M50.12 code. Now, looking at, we then carry on back to, as with all of our discals, is we've got thoracic region, thoracolumbar region, lumbar, lumbar sacral. Again, that M51 category does not have that directive or that note to indicate that we have to code exclusively to the most superior level. So if we have, for instance, an L4-5 disc herniation, so we've got an L4 and an L5 radiculopathy due to that L5 L4-5 and L5-S1 disc herniations, we're going to report M51.16 and M51.17. Again, looking at, these are disc disorders. That means either disc degeneration or disc herniation. We don't have separate codes for disc herniation with radiculopathy or disc degeneration with radiculopathy. It's combined together. So when you're looking at these, there are also codes out there that I was not able just to time length to include, but when you're looking at your documentation, identify your condition. So we have separate code categories for disc disorder with myelopathy. I just didn't give you those just from a time perspective, but knowing that looking through your ICD-10 codebook, we do have specific disc disorder with myelopathy similar to what we have in I-9. We have those new code sets for disc disorder with radiculopathy, that importance of that combination. We have other disc displacement, as I pointed out, other disc degeneration, and then we have other disc disorders. That's just kind of a catch-all. That's where we would be reporting the discitis perhaps from that aspect, where we're looking at other discal conditions. There's also separate codes for Schmorl's nodes in the thoracic and the lumbar region. Again, if we have documentation of that, we have those separate codes for that. And then we want to make sure that we have clear documentation of the site. My strong recommendation is, if you know the specific spinal level, document that, say C3-4, C4-5, rather than using the term cervical, because understanding in the disc disorder conditions, whether it's a disc degeneration, the disc displacement from that aspect, understanding that we've got separate codes for that high and mid. Likewise, we have that thoracolumbar for T12L1, lumbar sacral for L5S1. So just being aware of that. Now, shifting over, this is one of those interesting conditions, is that we've got where we have more specificity in ICD-9, where we have separate for cervical, thoracic, and lumbar region for post-laminectomy syndrome. We actually go to less specificity for M96.1, where they have less specificity in that. So again, important to understand, if you have been in the past, let's say the patient has both post-Lamy syndrome in the cervical region and the lumbar region, and you were entertaining doing a spinal cord stimulator both for the cervical region and for that either lumbar or thoracic region, and we were able to differentiate that. Excuse me there a second, just needed to wet my whistle there. If we needed to differentiate that in ICD-10, we'd have a single code. So where, again, if you're working on getting authorizations over the next few weeks, as I pointed out in part 1, be aware that we're going to have a single code post-laminectomy syndrome, not elsewhere specified. We don't have that specificity. Now shifting over to the osteoporosis, our pathologic fractures. Boy, my tongue is tied this morning. Our pathologic fractures. We have new combination codes. So in ICD-9, if you were, say, going to do a kyphoplasty or a vertebroplasty because the patient had a vertebral body fracture due to a pathologic fracture, not trauma. Now, these are not our trauma fractures. Our trauma fractures we'll talk about in our chapter S&T chapter. So again, in ICD-9, if it was an osteoporotic fracture, we'd report that as that 733.13 to identify pathologic fracture of the vertebrae. And then if it was applicable due to osteoporosis, we'd have to have a second code. Now, many of our Medicare contractor coverage policies for vertebroplasties and kyphoplasties, that vertebral augmentation procedure, required us to report dual diagnosis. They wanted not only that 733.13, but they wanted the underlying condition reported as well. Well, this is one of the bonuses of ICD-10. Yes, I know that we have lots of concerns for a lot of the additional specificity and a lot more codes, but this is, again, we have combination codes where we only need to report a single code. It captures both the osteoporosis as well as the pathologic fracture. So we have 4 different categories specifically for pathologic fracture. This is our first example of that X placeholder. So again, remember from part 1, in those codes where we are required to use that 7th character, if our code is only 5 or less in length, we have to have that X there. Now, if you're looking it up in your EHR, you're looking it up in your practice management software, it is very likely to be there. But if you're looking it up in your ICD-10 code book, that M80.08, and it'll have something to the effect of check 7th, will not have that X in place. So when the patient has age-related, that's the new term, instead of senile osteoporosis, they've now, to the more politically correct, age-related, as all of us are starting to get a little bit older, age-related osteoporosis, and this is specifically for with current pathologic fracture, specifically for vertebrae. Now, we don't have a separate code, whether it is, T11, T12, L1, or 2, and we don't have for one vertebrae versus multiple vertebrae. But again, you'll see that M80.08. Now, if the osteoporosis is for any other reason, we lose some of that specificity from ICD-9, where we did have separate osteoporotic for that separation out, where you can see where in ICD-9 we had separate codes for our idiopathic, our disuse, and then other, which included the drug-induced. That is now all grouped together into this lower that from that category, other osteoporosis. And as I indicated, this is the inclusion term, so it includes drug-induced, idiopathic, disuse, that post-oophorectomy, post-surgical malabsorption, or post-traumatic. It is not due to trauma. This is an important point to make. These are not to be reported if we have a traumatic fracture. So again, this would be osteoporosis due to the post-trauma. So again, we have that category of osteoporosis that falls under one of those others, we're going to report that M80.88. Now again, has to have that X in place. Looking at other reasons that we can have pathologic fractures, we have the M84 code category, where we have M84.58. Again, this is only 5 in length. This code requires the 7th character. Now, these two, in the pathologic in neoplastic disease and pathologic fracture in other, we don't have individual codes specifically for vertebrae, but the vertebrae are included as inclusion terms. So unlike in osteoporosis, where we have for the anatomic site, you can see on this slide where it's on slide 40, where it's specific to those code descriptors for vertebrae. When we've got pathologic fractures due to neoplasm, so we've maybe got metastasis, as this X-ray shows, L1 metastatic disease, or it's due to another disease that's caused a pathologic fracture. The code, if it's a vertebral body fracture, vertebral fracture, we're going to report that M84.58X with the corresponding 7th character, M84.68X. Again, this is an excludes one. This is either going to be if it's due to osteoporosis, we're not going to report that M84.68. It's either going to be due to osteoporosis or it's going to be due to other disease. We can't report both M80 and that M84.68. From that M84.68, we also have code also the underlying condition. So our ICD-10 code book, as well as our ICD-9 for that pathologic fracture and other disease, also directs us that we need to have a second code indicating what that other condition is. Well, now looking at the specifics for osteoporosis with a current pathologic fracture, the important thing to remember, particularly the second paragraph on slide 42, is that if this patient that has osteoporosis, let's say, walks into their kitchen and slips on a rug and falls and gets a vertebral body fracture, we are going to continue to report that as an osteoporotic fracture, because the directions in our ICD-10 guidelines say that even if the patient has a minor fall or trauma, If that fall or trauma would not usually break a normal bone, we're going to report it as M80, as an osteoporotic pathologic fracture. So most of us that are normal, if we have healthy bones, we can walk into our kitchen, we have a little slip fall, we may get a bruised bum out of it, but we're not going to have a vertebral body fracture. So that directs us that if we've got a patient, an elderly woman that walks in and slips and falls and ends up with an L5 vertebral body fracture, we're instead going to come back, and instead of reporting that as a traumatic lumbar fracture, instead we're going to look at that M80.08X code. So again, this is the importance of understanding, being aware of. I really strongly recommend our coders and billers and our providers, if you have the free time, to read those the particular guidelines that apply to the chapters that you report from. I've included them here on today's, but there are others in other chapters that you may report from. So looking at our seventh code, these are our options for vertebral body compression fractures not due to trauma. So we have A for initial encounter for fracture, D for subsequent encounter for fracture with routine healing, G with delayed healing, K non-union, P malunion, and S for sequela. So as I pointed out in our part one, that sequela is our new term for late effects or complications. The important thing, and I'm going to talk about it, and you'll probably think in ad nauseam, is that where we're looking at in the next few slides, what do we really mean is initial encounter versus subsequent encounter? The thing I want you to remember is initial encounter does not have anything to mean as to our type of E&M code that we report. We can report that seventh character A. If it's a new patient, we can report it if it's an established patient. It has nothing to do with the new patient code set or an established patient. Likewise, those codes D, G, K, and P, those 7 characters, have nothing to do that we're reporting in 99213, because in fact, you could have, theoretically, we could come up with a scenario that the very first time you're seeing this patient for that vertebral body compression fracture is that it's a subsequent encounter for fracture with routine healing, and it's a D, and you may be billing out the 99203 code. So again, here's where we look. The required care to identify the episodes of care. This is the 7th character extensions. That A is for the initial encounter. A stands for active treatment. So examples include surgical treatment, the evaluation and continuing treatment by that same or a different. So again, where we're doing active treatment. So the first time that you see this patient that has, we'll say, a neoplastic, so they have metastasis to a T12 vertebral body. That very first time that you see them, you're going to report that corresponding code, that M84.58X, and you'll report the A. Likewise, if you decide that the patient really needs to have a procedure done, let's say a vertebroplasty, then you're going to report that again, the M84.58XA. Now when they come back in for that third visit, let's say it's 2 weeks after the vertebroplasty procedure, and we're just going to routine healing. We're not doing any new active treatment. We may do x-rays to see how well it's stabilized, etc. Then we are not going to report the A. But again, that bullet point, highlight that if you have these printed. It is not the same as the E&M new patient. If you're seeing them in follow-up, that's going to be our subsequent encounter. So you're going to report that as a D. So let's say we have the patient who had the slip and fall in the kitchen. And it was, we're going to say that it's age-related osteoporosis. So again, we're seeing them in follow-up. You've already done the kyphoplasty to the L1 vertebral body. you're seeing them 2 weeks out. You're going to report that M80.0XD because we have routine healing. It's going to require our providers to note that we have a delay in healing or a malunion or non-union. So from that aspect, these are examples from our ICD-10 guidelines that, now granted, we don't do casts on vertebral bodies, but again, we can have pathologic fractures that we may not see, but certainly orthopedic providers, but this gives you the idea of what falls under that reporting that D, that subsequent encounter. X-ray to check healing status. In fact, even if they have a surgical procedure to remove an X-fix and internal fix, again, not interventional pain management kinds of services, but it gives you that concept of what we're really trying to identify in ICD-10 with that subsequent encounter definition, that Medicare adjustment, other aftercare. So instead of reporting like you may now a V code for other orthopedic aftercare, you're in fact going to continue to report for the pathologic fracture that M80.08 if it's age-related osteoporosis, M80.88 if it's other osteoporosis, if it's neoplastic, that M84.58, or if it's pathologic fracture in other diseases, M84.68, all with that sixth character X, and then we're going to continue to add in, as long as it's routine healing, that D. Again, not the same as a 99213, just because you're seeing this patient as a follow-up, as an established, because theoretically, now this doesn't happen very often, but a little old lady comes to Colorado, has a slip and fall. She has it treated here in Colorado, and she goes back to see you, and you're in Kentucky. And so you're seeing them for the very first time, and it's maybe a new patient, but you're seeing them for follow-up care for this osteoporotic fracture. You're going to then, the very first time you see that patient, because it is for aftercare, you're going to report that M80.08XD. And you could then have that 99203 or 99204 code. So again, whether it's a new or established has nothing to do with the seventh character extension. Then looking at our other options, G, we don't have anything from ICD-10 that specifies what that delay is. We're going to have to rely upon our providers to document that. A non-union, from an FDA perspective, that's a minimum of 9 months post-occurrence, and it's not healed, it's not shown a radiographic progression for 3 months. That's the FDA definition of non-union. Malunion, again, the K and the P are going to require that our providers document it. And then likewise, sequela, where we have indications. This is replacing that phrase of late effects where we were reporting maybe that 905, 906 code in ICD-10. We would continue to report that pathologic fracture code and then add that S. We would also then report what that actual specific sequela as the primary code. So looking at documentation, in osteoporosis, we're going to first identify whether that patient has a pathologic fracture or not. We want to make sure that we identify that type or cause of osteoporosis, whether it's age-related, localized, other, from that aspect. If where that current pathologic fracture is, now certainly in interventional pain management, we're most typically going to have the vertebrae, but I just wanted to show you there are many other codes out there that say orthopedics may see for pathologic fractures, let's say of a femur fracture or a humerus fracture. And then again, we have that episode of care, understanding that if we're doing active treatment, that's going to have that A, seventh character. If it's follow-up care, having clear documentation of that, and that will be that either that seventh category of D, G, K, or P, depending upon what the healing is or if there's malunion. And then last but least for sequela. Well, shifting out of pathologic fractures, we go from our other musculoskeletal symptoms from that aspect. We've got our where we have an expansion of spasm of muscles, that 728.85 expands to M62.830, M62.838, where we have muscle spasm of back and other muscle spasms. Unfortunately, in ICD-10, like ICD-9, we don't have specificity for a code specific for trigger points. We know in ICD-9 we frequently report the 729.1. We have separation for anatomic site for myositis. Now, many interventional pain management providers aren't comfortable, don't feel that that's the appropriate diagnosis for trigger points. But the point I want to make is we do have a separate code for fibromyalgia. So as you're doing your crosswalk, where we might have reported 729.1 for patients with fibromyalgia, we want to make sure that we have those carved out and we have them indicated as that M79.7. We don't just default to that M79.1 crosswalk. Pain in limb, we have much more specificity, that 729.5 for you interventional pain management providers that maybe do electrodiagnostic tests. If we have a normal study, you may in fact be reporting that 729.5. We have separate codes for differentiate laterality and upper and lower extremities, as you can see at the bottom of slide 50, that M79.601, 602, 604, and 605, right, left arm, right and left leg. But we also have specificity within those limbs. So on 51 and 52, you can see where we have upper arm, forearm, hand, and fingers. Again, these are excludes 2 notes with that pain in joint. So if we had a patient with pain in limb, so we have a pain in that upper arm as well as pain in the wrist, we could report both codes. But if we have pain in forearm and it's really forearm down by that wrist and it's pain in wrist, we're only going to report that pain in wrist. So from that aspect, and here's our lower extremity, pain in thigh, pain in lower leg, foot, and toes. Moving out of the musculoskeletal, we're not going to spend a lot of time on the pregnancy. The important thing I want to point out is if any of your providers do blood patches for labor epidurals, so where they've had the patient picked up this condition because of the labor epidural, they have postpartum headache, spinal headache. We're not going to report that headache code that we talked about in part 1 down in our spinal, in our nervous system with the G code. We are in fact going to report the code from this chapter. Again, what is our ICD-10 codes always start with? They always start with an alphabetic character. So this starts with O00 through O9A. That's our code categories for pregnancy, childbirth. The sequencing priority, this is no different than ICD-9. This is not a change, is that if it is due to a pregnancy-related condition, we need to be reporting this instead. And so our code would be actually, that is O89.4. That is spinal and epidural analgesia-induced headache during the puerperium or during that postpartum. They do have sequencing priority. So if your provider is doing a blood patch for a spinal headache following a post-labor spinal headache, you're going to report, instead of that 668.84 like you should be reporting now, you'll want to make sure you report that O89.4. And again, that is O, not 089.4. Shifting over quickly into the congenital malformations, chromosomal abnormalities. This to point out is this can be reported at any stage in life. It's not just at birth. We can report this on an 80-year-old patient, any of these. These are our Q codes. We've seen a little bit of them already. So we have, right now, we have the 75611 for congenital spondylolysis and 75612 for congenital spondylolisthesis. Now remember, in ICD-10, we default to the acquired, so our providers are going to have to document it. Even though we have separate codes in ICD-9 for spondylolysis and spondylolisthesis, in ICD-10 we default to a single code, that Q76.2. And in fact, the congenital spondylolysis is an inclusion term. It is valid to report that Q76.2 for congenital spondylolysis. We don't have that spinal region specificity for congenital that we see in the acquired in ICD-10. So just remember that we have a standard single code for congenital spondylolysis and spondylolisthesis that's reported with that Q76.2. There isn't separate codes for lumbar sacral from that aspect. Now, looking in signs and symptoms, this is frequently reported when we don't have a definitive diagnosis. Maybe the patients come with signs and symptoms and they never came back to get the final diagnosis from that aspect, or we're working them up for their condition. So again, one of the examples is if that patient happens to have what we call white coat syndrome. They don't have hypertension, but they do get elevated blood pressure from coming in and seeing our doctors. And that might be reported with that R03.0 elevated blood pressure reading without the diagnosis of hypertension. I'm not going to spend a lot of time on our guidelines. We've got a couple of here. The big part is if our signs and symptoms are considered to be an integral part of that disease, we shouldn't separately report the signs and symptoms code. So if we know that, low back pain is associated with spondylosis, we're not going to go ahead and report low back pain as a separate signs or symptoms from that. If we know that that patient has hyperesthesia as an integral part of CRPS, we're not going to separately report that hyperesthesia diagnosis code. If it's not considered to be integral, then we can continue to report them. Also, we shouldn't, in this, the combination codes that include symptoms, for example, that M50.12 cervical disc disorder with radiculopathy, we should not be separately reporting that radiculopathy code M54.12 radiculopathy cervical region as well. So we've got good news for our abdominal pain. We have our standardized one. They're slightly in different order than what we have in ICD-9. From that aspect, that paraumbilical is actually shifted down out from that R10 category, as well as the right lower quadrant and left lower quadrant. Paraumbilical is in a subcategory separate, but the big point is that we now have a code for pelvic and perineal pain. No longer do you have to report a diagnosis such as 608.9, unspecified disorder of a male genital organ, for male perineal pain. We actually have an R10.2, so we do have a new and improved from that aspect. Other ones that we see, 782.0, again, frequently used by interventional pain as we're working patients up because patients may have numbness, may have tingling. And so we have that specificity for anesthesia, hypoesthesia, paresthesia, hyperesthesia, and then a code for other disturbances of the skin sensation. Now these we can report as many, so if we have we have pins and needles and we have some numb areas. We can certainly report our 20.1 as well as our 20.2. Just to point out, difficulty in walking has been pulled from the musculoskeletal chapter in ICD-9 over to the signs and symptoms and would be reported with that R26. Now looking at our injury chapter. Now these are our injury codes. This is specifically associated with injury. This is an example of where a chapter actually covers 2 alphabetic characters. So our S chapter is to specific body regions. Our T is unspecified, includes burns, poisoning, external causes from that. And these, almost all of them are going to require that placeholder X, and almost all of them will require that 7th character extension because that's associated with injuries. One of the big changes, as we saw in osteoarthritis, our first axis for osteoarthritis was the anatomic site. Likewise is the organization for our injury codes. So right now, all of our codes for injuries are sorted by the type of injury. All of our sprained strains are together. All of our open wounds are together. All of our fractures are together. In contrast, in ICD-10, we have it by anatomic site. So all injuries related to the neck will be found in those code categories S10 through S19. Likewise, in that lumbar spine abdominal area, you're going to find all injury codes in that S30 through S39. So from that aspect, then our 4th, 5th, and 6th provide identification of the specific type of injury, laterality, specific anatomic site. So In ICD-9, our sprain strain codes are actually together. 847.0, sprain strain of the neck. In ICD-10, we actually have separate codes, so I've provided them here. Now you can see that sprain of ligaments of the cervical spine, that S13.4, is only 4 in length, so that's going to need to be padded in with 2 of those placeholder X's. And then we require that 7th character. So again, anywhere in my handouts where you see that dash sign, that's indicative that an additional character is present that is necessary. In this case, we only have the 3 7th characters that are applicable for that character, for the categories S13 and S16. That's A, initial encounter, again, that's our active treatment. D, subsequent encounter, that's our follow-up. And S for sequelae. We don't have all of those additional ones like we see in the fracture codes. And so then we go in 847.1 and 847.2, where we're looking in the thoracic and lumbar regions. Again, we separate out sprain of the ligaments from the thoracic spine, strain of the muscle and tendon in the back wall. Now that code, the S29.012, is already 6 in length, so we don't need any placeholders. Likewise, the S39.012 for strain of muscle in the lower back. Again, from looking at this aspect, our 7th category code, 7th characters are, again, for all of these, whether it's categories S23, S29, S33, and S39, are A for that active treatment initial encounter, D for subsequent encounter for follow-up care, and S for sequelae. So again, I'm not going to spend a lot of time going through these. We've been through these before, but again, looking these, it's not based on whether you're seeing the patient for the first time. You can certainly read these on your own time. But again, that A is for active treatment, evaluation, and active treatment of that patient, where D is, again, where we're doing that follow-up care, medication adjustment, other aftercare follow-up visits. And then the S, again, is for sequela, for complications. I just want to give you a quick example for those narcotic-induced effects where we have an adverse effect from the medications we're prescribing. Now, an adverse effect is for medications that are taken properly. And so I've just given you in the bottom of slide 70 some of the examples of the corresponding adverse effects. So it might be constipation, might be dermatitis, hyperalgesia, where we've got hypogonadism, prolonged QT interval, respiratory center depression, or somnolence. These are all due to the adverse effect of the narcotics that that you're prescribing. And so where you would go, you'd go to the that alphabetic index and look under the table of drugs. Like on slide 71, I've just done a quick excerpt. This is just of narcotics, but they have them of opioids, of methadone, synthetic narcotics, other narcotics. That first column is accidental. That's when the patient is poisoning. That's where they've taken more than they should, and it was accidental. Intentional is when they're taking it intentionally wrong. They're either taking in more than they should. They're taking it with their Jack Daniels. They're taking it with, any alcohol substance. And the poisoning is maybe when their spouse is giving them more than they should. The column that we want to look at for adverse effect is, again, that adverse effect column. That underdosing is not really going to come into play. That's a new column, new concept for ICD-10. That's where patients are taking less because they have financial restrictions. In interventional pain management, the vast majority of our patients don't take less meds than they should. In fact, they frequently take more. So from that aspect, if they're taking, it was prescribed correctly, it is the right prescription, they're taking the right amount by the right route, they're not crushing it, shooting it up, we're going to use that column for adverse effect. And so I've just provided them. These codes do require that 7th character. They are 6th already in length. This is an example of some of them that do have an alphabetic character in that 4, 5, and 6 that is not that padding, that extender kind. The T40.2X5 is a valid code that is not padded in place. That is what the code is. You can see for adverse effect of other opioids. And just to give you an idea, so if patients are having complications of the drugs, we really should identify the drug as well as I've given you on slide 70, some of the examples of that, the corresponding, the side effects, the sequelae type. So finishing up here in Chapter Z, well, Chapter V became Chapter Z. So from this aspect, this is reported when a patient that's not currently sick has a healthcare encounter. They've maybe got a resolving disease or injury, chronic long-term condition, circumstances when they influence a patient's health, but in themselves are not a current illness. And so again, these will be our corresponding V codes. I just wanted to give you that example. Again, you might have been reporting the V54.27 for aftercare of healing pathologic fracture when you were doing a vertebroplasty and you're seeing them follow up. That is not correct for ICD-10. You're going to go ahead and report, as I said earlier, and report the corresponding injury-related code, whether it's osteoporosis or pathologic fracture and neoplastic disease or other disease, with that placeholder X and the corresponding seventh character, which would likely be D for routine healing or G for delayed healing for that aftercare. And then we have our corresponding code V58.69 that we routinely report. We have a carve-out. Instead of just other medications, we have for opiate analgesics. So this is the code that we're going to be the go-to code that we're going to specifically report when we're looking at drug testing. And I can tell you I looked through every one of our coverage policies for Medicare contractors, and all of them do include that Z79.891. They have some limitations in that opiate abuse, that opiate dependence, and opiate use codes. So carefully look through your coverage policies, but all of them, in fact, did include that Z79.891, and many of them did include that Z79.899, that other long-term drug therapy. Now, V15.81 is used by some practices for patients that aren't compliant from that aspect where maybe they're taking more meds than they should, so they have an early refill. They've got a lost script. They have a repeated lost script. We have now a little additional specificity, so that Z91.14 is for patients' other noncompliance with medication regimen versus just that other medical treatment. I just want to finish up here, and before I look at some of the questions, how are you at for your clinical documentation? Are you ready for ICD-10? And so again, in these next few weeks, I really recommend that practices, if you have that capability to do that gap analysis, run a report, have your third-party billing services run a report. I talked about this a little at the end of part one, is to find out where you want to be and where are you at. Get that gap analysis. Can you code from your current documentation? Are we missing right or left? Are we missing that it was C7T1? You know, those types of things, and have our providers point them out to our providers so they can proactively make corrections on our documentation. The next are just some, I found these 6 C's in doing some of my research, and I just thought they were pretty appropriate. I'm not going to spend a lot of time going through them. We've got 3 slides here, but again, just making sure that our documentation indicates that medical necessity, making sure we've got that laterality versus bilateral when they're paired anatomic locations. Clarity, be aware that more than just you read your notes, and in fact, many referral sources, nurse case managers, claims adjusters, attorneys, can that reader understand and follow your ideas to provide that continuity of care? Make sure that your current patient problem list is up to date, whether it's inside your note or it's a separate one. Are your medications up to date? Be very careful. Have resolved medical conditions been removed? Make sure that we have that cause. That underline, make sure that if it's probable, suspected, it's good to document. We can't code from it, but that allows us to look to see where you're thinking this patient's going to go, particularly in injury-related claims. Those chronic conditions, as long as they have an impact on the patient's care, you should report them, and you can also code them. So finally, just as for specifically for pain management providers, those last little ones, make sure that anatomic location, the spinal level, that laterality, right versus left versus bilateral, that seventh character visit. Remember, A is active treatment. That D is for follow-up care. Don't forget to add your placeholder character, that X, if you're looking it up, and also make sure you understand that excludes one. Only one code can be reported. Make sure that if you're reporting your ICD, your PQRS on claims, make sure that you switch over to ICD-10. It is a requirement that you report. If you continue to report your PQRS measures on your claims with ICD-9 codes, it will not be valid. If you use your diagnosis codes as searches to find your various patient instances for your registry, make sure that you're going to have to search both with I-9 codes and I-10 codes. And I've just finished up here. This is many of the areas out there. If some of you, we had a pretty high percentage on the part one that said they were just getting started. There is a plethora of information out there. Emily, I'm going to look at some of the questions here. I know I've ran a bit late. I apologize for that. I just had a lot of information that I wanted to make sure that we got coded and reported to our attendees. So I'm going to go ahead, and if you can repeat to them again how they can put answers in, that would be greatly, or questions in, that'll be greatly appreciated.
Yeah, and I'm sure your attendees are very, very grateful for you being so thorough. And for our attendees who would like to ask Marvel a question, feel free to navigate to that Q&A tab at the top of your screen. Once you've gone ahead and selected that tab, you'll click on the button that states Ask New Question. From there, you'll type your question in the My Question box and select the Submit button to register it. So, Marvel, we have gotten quite a few questions that have come in through the duration of the program.
Right, and some of these I think were possibly done early on, but I'm going to pick through some of them that are particularly. So, do you think myalgia code M79.1, actually, that one was retracted, taken away. So, and while I'm looking through these quickly, here we go. Do you think myalgia code M79.1 would be good for most payers for trigger point injections, or do we need to specify sites with myositis? Well, you know, in many cases, providers aren't comfortable with the myositis diagnosis. So the M79.1 for all of you attendees is myalgia. An inclusion term is myofascial pain syndrome. What I would recommend is to look through your payer coverage policy from that aspect. And look, in some cases, some of our payer coverage policies for ICD-9, in fact, use some of the enthesopathy codes to identify specific modifiers. And so from that aspect, you know, you want to make sure that you follow your payer coverage policies as well. Are we going to still going to use the modifiers? Well, as I pointed out in part one, yes. Just because we have RT and LT as in identified for right and left or bilateral conditions, we will still continue to need to report the 50 modifier for Medicare for bilateral, or in many of the cases our payer coverage policies request us to use the RT or LT when it's a unilateral. So yes, just because we've got specificity in our diagnosis codes does not prevent us from the requirement of still using those modifiers to indicate in the procedures. And so here, why would an authorization required in September with an ICD code possibly be invalid if the procedure is the same? Well, the aspect that I was indicating in part one is, let's say we've got that pre-authorized for the 29th of September with an I-9 code, and the patient cancels, something comes up, and now we move that back to October 10th. And we're going to report that October 10th procedure now with an I-10 code. And so I don't say you have to where you're getting that last few days of September. Just be aware that if that patient is moved back to an October date of service, we're going to need to report that. Why do some categories require full 7 digits as others not require the placeholders? Well, first and foremost, the placeholders are only required for those that require that seventh character. And so those are our injury codes, those are external cause codes, and some obstetric codes. And so the vast majority in interventional pain management, we don't report a lot of injury. We certainly don't report a lot of obstetrics. And likewise, the external cause codes are not a requirement. It's not a national requirement. So I just wanted to point out so that you're aware of it. But just like in I-9, we have some valid 3-character codes. MS, likewise, MS and ICD-10 is a 3-character code. So from that aspect, where we have, let's see, I'm trying to scroll through here. I'll take a couple more. So patient sees us for diabetic neuropathy. What code is first, cause or due to the neuropathy code? Well, this is a great question because remember, this is specific to we have a combination code for the diabetes. So the diabetic neuropathy is going to report it with a combination code. So we're not going to have a need to report two diagnosis, two ICD-10 codes. We can get it, with an E11.4. I don't have them totally memorized yet, but for that 5th character there. And so from that aspect, just be aware of it. So if a patient sees us for the first time for back pain, but has seen another provider before us for the same reason, and that referred patient to us, how would we report that? Well, you would report as you would now. You're going to report it as back pain because, again, the 7th characters don't affect the back pain. It is only for, let's say it's only for specifically for the injury codes, and back pain is not considered to be an injury code. It is a sign and symptom found in the musculoskeletal system. Emily, I'm going to take one more, and then I'll look at these offline from that aspect as I'm scrolling through, trying to find, not take them from all of the same person. Radiculopathy, I just had that. Radiculopathy and sciatica are equivalent. Should we use both codes even though they mean the same thing? And in fact, we actually have now in ICD-9, we have a separate code for sciatica as we do neuritis, radiculitis. And so if we know that it is of that specific sciatic nerve, then we would only report the sciatica from that condition because the radiculitis, the radiculopathy, unless we have other spinal regions, other spinal levels. So if we have, sciatica along with, let's say, cervical radiculopathy or upper level lumbar radiculopathy along with the sciatica, the patient has multiple different conditions going on. That's when we would. But if it's only coming from the dermatomes of the sciatic nerve and we have a true diagnosis of sciatica, we're only going to report that the ICD-10 code for sciatica, which is not any different from what we have in ICD-9. Emily, do you have any final notes for them as to getting any of the handouts? I see a couple questions again about the handouts, etc.
Yeah, absolutely. So for our attendees who would like the PDF version of the slides presented today, you can feel free to navigate to that Materials tab at the top of your screen, and you'll see that the materials are provided in a 1-per-page or 3-per-page PDF format. So you can feel free to download those. You can save them, print them out, whichever you would like. Also, in terms of the archives for the presentations, our first presentation has been made available as an archive, so you should have that in your ACIP classroom. And we'll also be providing you with the archive for this session directly after it's produced. It usually takes about 24 to 48 hours, so just keep an eye out for that. I will be emailing you once that archive has been made available with the archive link for viewing. And Marvel, at this point, if you do have any closing responses or key takeaways that you'd like to make, feel free to do so.
Thank you very much, Emily, and thank you all for attending. I know this has taken a big commitment for you all to take 2 days out of your busy practices, but I really think it's important that now you have some of the tools to go forward. Make sure that you are getting comfortable with these codes, particularly for those that do billing. We're needing to make sure that they go out as clean claims with dates of service on or after October 1st for those payers that require that. And I hope you all have a great day, and I probably am the only person looking forward to October 1st. So everyone have a great day.
Wonderful. And on behalf of ACIP, I would like to thank you all for joining us today and for your excellent participation. I would also like to extend a huge thank you to Marvel for her amazing presentation throughout these past 2 days. At this point, I will ask that you take a moment to fill out the brief survey that I've just brought onto your screen. This certainly does help ACIP in planning for future webinars, and we certainly do appreciate any feedback you are able to provide. Again, thank you very much, everyone, for joining us today. This does conclude today's session. To disconnect, simply exit out of your browser windows.